Screen. There we go.
All right.
Are we clean and clear?
We are good. Thank you.
Okay. So we'll start over here. So we'll start off with the anatomy first. I want to go over the bones of the knee for those that didn't catch this. We have the femur, which is your thigh bone. We have the tibia, which is the lower shin bone. We got the fibula, which is going to sit just outside of that tibia, and then you got your patella. The patella is going to play a nice role in the fact that it kind of connects the upper part of the leg with the lower part of the leg. So those are the four bones that make it up. The reason I have hinge joint kind of highlighted in red is that's going to become kind of an issue down the way when we talk about how injuries occur and kind of what happens to the knee joint itself. So think of the hinge joint, excuse me, the knee like a hinge joint like you'd find in a door that opens and closes. Okay, so just keep that in mind. Now we go to the ligaments of the knee. As a lot of people understand the ACL, PCL. We have a lateral collateral ligament, medial collateral ligament, of course, the meniscus. So this picture over here kind of shows you where everything sits and how everything sits into the knee itself. The thing I want you to take away from this is remember ligaments connect bone to bone. That keeps the proximity of the bones together so the muscles can move them around. So that's also important to remember as we go through the function of it all. I brought up the muscles of the hip and the knee simply because the hip plays a role in how the knee functions. So you got your hip flexors and your quads, you got your glutes, and you got your hamstrings. They all play together a little role with the knee and how it functions and moves, as well as the muscles down towards the ankle, so in your calf muscles as well. So all these muscles play a role in the function of the knee, which we'll get to just here in a little bit. The question we have is how injuries happen to our knees. So we started off, I mentioned how the knee is a hinge joint. So if you can picture a door with hinges on it, and you open and close that door a billion times, those hinges will technically never break. They'll just kind of keep on opening and closing. So the knee joint is very much the same thing. Now the difference is if I start hanging on the end of that door with all my weight and try to open and close that door again, eventually I'm going to start wearing down that hinge. So that's when I keep talking about the hips and the ankle and the function between them all. The knee joint is that hinge joint in between that we're putting all that weight on. So the hips are meant to bear weight, the ankle joint's meant to support and move. The knee is just a conduit between the two. What happens is over time, we start breaking down the tissues within the knee, and that's how we end up with some of that pain. So the common causes and types of injuries that I'm going to see in my office, or we'll see in general, spraining of ligaments is a very common thing you'll see. You have ACL sprains, PCLs, MCLs, and the rest. A lot of people equate meniscus with being torn, but you can actually sprain them as well. Pulling of the muscle, quad pull, hamstring pull, calf pull, all very common injuries as well. And you can strain your calf, which will directly affect the way your knee is going to perform or move, and also the joint itself. Strain of a tendon is something we are familiar with. Patellotendinitis, Achilles tendinitis are all things that are contributing to the knee function as a whole. Now, the caveat is you can actually sustain a trauma to the knee. So the ACL, the ligaments talked about, ACL, PCL, collateral ligaments. The trauma is where you take a blunt force to the knee, the side of it, the front of it, however you kind of attack the knee there, and you actually will tear the ligament entirely or tear a meniscus. So those traumatic events are generally pretty memorable, so you don't really kind of wonder how that happened. The most common thing I want to see in my office, though, is going to be your wear and tear injuries. So somebody going out for a run or playing tennis, and all of a sudden they hit a shot, they come back and they stop, and their knee starts to hurt a little bit. They're in 2 miles of a run or a 3-mile run, their knee starts to hurt a little bit. Things that kind of come on very slowly. Wear and tear is typically going to be caused by a dysfunction within the system. System can be anything from your core muscles to your hip down to your ankle joint, and everything kind of in between and how it works. Those would qualify as a cumulative trauma cycle or cumulative trauma syndrome. I like the cycle side of that. What that means is you have little micro traumas that occur to the ligaments or the muscles or the tendons and even to the joint that accumulate over time. So weeks and months and years of constant kind of pounding on them, they start to wear down. Much like if you stretch a rubber band too often, too much, it'll start to tear a little, wear a little bit. That wearing is a little sprains and strains that we accumulate over time. The cumulative trauma cycle or the pain is going to create dysfunction by the nature of what it does. So when you build up scar tissue within joints, ligaments, tendons, and things of that nature, that scar tissue and those strains will constantly cause the body to have to compensate with how it wants to move. So that could be getting out of a chair, getting out of a car, whatever it may be, the mechanism and the methods by which you do that movement or perform that movement, they get altered by these type of pain cycles. Bad hip function, bad ankle function are going to equal bad knee function, and eventually lead to an injury. Now, when it comes to sports, which is obviously we're going to get a lot of these common traumas where you get the tears in and so forth, most of sports that are going to be causing these problems are going to be sports where you have to jump and land, you have to stop with a sprinting motion, or twist or turn laterally. So tennis and soccer and basketball, all sports that are very common. Football, of course, with the trauma to the front of the knee. So these are all sports with your stopping motion or trying to redirect motion. That's where the ligaments can sometimes get strained or pulled. So those are areas in the sport that we always try to focus on as well. So treating knee pain and what caused it. First and foremost, you have to assess if there's a trauma. So trauma, again, you don't forget that trauma. You know it happened, you felt it, you know it's there. Past that, you get the cumulative trauma cycle, bad hip or ankle function, all the above. One side note I want you to remember is rest does not equal recovery and healing. So you may pull a muscle and strain a muscle or injure the joint or sprain a ligament, but just by resting alone, you don't actually fix that tissue. The inflammation and the pain goes away, but the tissue damage is there and the functionality or dysfunctionality that goes around it remains the same. So always keep that in mind. Rest is good, it's important, it's part of healing, but it's not the only piece you need there. So when it comes to treating knee pain, okay, not to fly through this too quickly, but treating knee pain is kind of complicated as well. First thing you have to do is assess. So we need to find out if you have poor hip function or ankle function, both, we're not really sure. But you want to make sure you get an assessment on it so you understand that a knee joint itself isn't usually the problem. It becomes part of the kind of the end of what all the problems have accumulated to become. Soft tissue work, I do active release technique in my office. I do a lot of knees in the office, and active release technique does wonders for it. The goal there is to break down scar tissue that either had accumulated prior or was accumulated since the injury happened to you. Okay, breaking down the scar tissue just restores function around the joint. The joint can actually take the stress off the joint itself. Kinesio tape, I use rock tape, kinesio tape, rock tape, either way, it doesn't matter. They both work great. You can apply it to helping the muscle function. You can keep ligaments, kind of mimic a ligament movement. I have somebody's volume that's chiming in. I can't talk over it. Are we all muted?
Hi, is there somebody on a cell phone? Their phone isn't muted. Thank
I love
you.
the sounds. Perfect. All right. So that's kind of the treatments that you do in a clinical office like you do in mine. For a lot of people who have if you have more of a home strategy or things you can do at home, foam roller is by far one of my favorite things to do. You can treat the tissue similar to what I'd be doing, but it can actually roll out the muscles of the hip, down the leg, into the calf, and even in the foot. And they can kind of help break down some of the scar tissue, increase some of the lymphatic drainage and blood flow, and get you moving a little bit, kind of help treat yourself. Nutrition, number one thing I focus on with all my patients. I have to think what I put into my body is going to help my body heal. So if I'm eating really well, whatever my tissues need to heal and get healthy again, I've fed it in there, and we just got another sound again. Everybody muted there? Hello, everybody muted? Anybody? Think we're good? Okay. From nutrition, we get to hydration, which we often overlook as well. Even when you're injured state, hydration is really important to keep up with. Keep the tissues as healthy and hydrated as possible. The rule of thumb is if you basically weigh 200 pounds, you want 100 ounces. You want half your body weight in ounces of water. That's what you're going to drink every day. You have to take into account your exercise output, but if you're injured, hopefully not exercising too much, and any heat, humidity that's around the area you live in. Rehab and corrective exercises. So I have a couple of links on here to YouTube, some of the exercises to kind of give you a visual on what they look like. The key here is the assessment portion that leads into this. I like to focus on stability and controlled movements. Remember, it's the hinge joint we're dealing with. So you want to control the way that hinge works. You don't want to hang on the end of that door too much. Basic rehab exercise I give pretty much everybody that's going to have a knee issue. We're going to have clams. You got a glute ham bridge, a single leg glute ham bridge, and then your planks. The whole goal there is to kind of establish your control system, your core system, your hip function, the things you need to support your knee, because when you go through that injury, the compensatory patterns are going to kind of turn off that normal functionality that we have and replace it with a dysfunction. And we want to make sure we eliminate that and bring back in a normal function for you. After that, calf raises. Believe it or not, calves play a huge role in the knee function and also recovery. So begin with both feet doing a calf raise. You can move yourself to calf raises on a single leg, but take your time with that. Don't rush through these. Ankle alphabets. If none of you have ever done these, they're kind of fun to do anyway. You can lay your foot off a bed or a chair. Keep your legs supported. You're basically going to draw capital letters for the alphabet, A through Z, Z through A, just with your foot and your ankle joint. So you want to make sure your leg isn't moving and doing all the work. You want to make sure it's just your foot doing the work. Even if you're healthy, you actually find those to be rather challenging. And single leg balance. You do not need a foam pad or an uneven surface or anything crazy. Just do single legs, standing on the ground, barefoot preferably, and I have a picture here next of how you want to do this. So the person on the left in the pink top, she's holding upright the way I want it to be. Eyes forward, chest up tall, tummy's tight, the leg is at 90 and 90, and your foot is relaxed. The young lady on the right, the problem we have here is her eyes are looking down, her hands are on her hip, and her foot, you can see, is pointing up pretty well. What she's doing is actually creating a compensatory pattern into her balance training. So for her to balance or use her balance system, she has to look down, generally keep that toe really active on the bottom there, and maybe have to have her hands on the hips. We like the other one here where everything's kind of relaxed and you're maintaining a good posture and position. So that's what we like there. Some other treatment options we're going to talk about a little later after me. You got a platelet-rich plasma or your PRP shots, stem cell regenerative therapy, and of course photobiomodulation or LED red light treatments. All of these are fantastic to use. Obviously, depending on the severity of the injury, depending on which ones you're going to use for all those. And now I just want to walk through some of the pictures, because pictures are nice to learn from. So when we talked about rolling out earlier, this is rolling out your calves. So you can see how she's positioned, crossing the leg over just makes it a little more intense, so it's a little more tender or just uncomfortable. When you're doing this, try not to roll out big sections of your legs. Try to do 6 to 8 inches and hit little pieces going up from your heels all the way up to the back of the leg there. Here's a calf stretch. I'm a big fan of ankle mobility stuff. So the one on the left, the bottom, that's just a basic calf stretch, getting your foot propped up on something. If you don't have access to something like that, you got the one on the wall. With the one on the wall, there's 2 positions you can do. The first one is as you're seeing in the picture here. The second one is the leg that's behind her. Just simply bend that knee and then kind of do it like the arrow is showing, and allow that calf underneath the second calf, the below one, to get a stretch in there too. Okay, all your stretches you're going to hold for 30 to 45 seconds. Calves are very dense tissue, so you can stretch them 4, 5, 10 times a day, and you'll be good there. This is rolling out the quad. So we roll out the quad. The arrow has a nice depiction of how to go up and down in that area. You can also bring that body over to the lateral side or the outside of the quad and hit that same spot. The outside is going to be more tender than the top usually, so just be careful with that. Your IT band syndrome type issues that you'll run into, this is a great move, especially on the outside of the leg. Again, when you do this, small chunks. Don't do the whole leg, okay? This is rolling out your glutes, one of my favorite ones. You're going to roll out the glute of the leg that's crossed over the knee. You're going to roll this section here. The muscle's not real big, so when you're rolling it out, you're only going to hit little spots on it anyway. When you find a tender spot, you want to go after it a little bit, but to your tolerance. This is just a little pic here of just some basic stretches of all the hip stuff, all the abductors and hamstrings and quads and so forth. You can do this throughout the day too. I'm not a big fan of stretching the knee per se, only because the knee is a hinge joint, doesn't necessarily get tight. Your hips and ankles will get tight, but the knee joint itself is performing a couple ranges of motion, so it doesn't really get stiff or tight or shrink in range of motion until the joint gets affected, which is a whole other animal, all right? And that's the end. So I got through that, hopefully enough time for everybody. If you have any questions, let us know after. And I'll turn this over to, hold on, let me get here.
Conley, thank you. Hi, everyone. So today I'm Rozina Badal Munir, and I'm going to talk about the imaging of the knee joint. Most of the part is already covered by Conley, so just a brief and quick anatomy. You just see over here, as already Conley explained it to you, that the knee joint is one of the most weight-bearing joint, and it is formed between the femur and the femur, which is the bone of the thigh area, and this is the tibia. So the joint is between femur and the tibia. So you can look at over here, the condyles of the femur joined with the condyles of the tibia. And in between these two joints, there is a small little fibrocartilaginous structure, which is the cartilage over here. And you can see there are different muscles, and they form the tendons, and these different tendons then stabilize the knee joint. So you can see over here, this is the most bigger one, which is called the quadriceps tendon. And the quadriceps tendon is formed by different muscle tendons which join together, and it attaches onto the patella. So from the patella, the tendon joins downwards, and it attaches to the tuberosity. So you can see knee over here. So this is the knee shown over here, and this is the structure of the ligaments which are attached to the knee and make the knee joint. So the quadriceps tendon is the main one. Then on the lateral side, you see these small little slits. So these are the collateral ligaments, lateral and medial collateral ligaments, which help in the left to right stabilization it gives. And let's go to the next slide. Okay, on the back side, we also have different muscle tendons, which forms the posterior part of the knee joint, which is called the popliteal area. The internal part of the knee joint is stabilized by these small little tendons which are crisscrossed, and these are called the cruciate ligaments, anterior and posterior, and they give the anterior and posterior movement of the knee joint, so they stabilize that movement. In the popliteal area, you will also can see that the nerves, artery, and veins passes through this area, so which are seen more easily from here. Then beside that, the knee joint contains a lot of bursa. So bursa are small little pockets of free fluid pockets. So they give they act as a cushioning for the movement of the tendons, ligaments above the bone. So it helps in the avoiding the friction. So you can see all these are the small little areas called the bursa. The most common bursa is the biggest one is the suprapatellar bursa. Now coming to the imaging, there are a number of ways by which the knee joint is evaluated. So the most common are the X-rays, the MRI, the CT, the ultrasound. These are the most commonly used the imaging modalities which are used in the clinics and in the hospitals. So if you now look at over here, this is the X-ray. And on the X-ray, you can see this is the bones of the femur, and this is the tibia. And you can see how nicely you can see the your knee joint. You can see the space between the two bones. And beside this, you can see the this bone is the patellar bone. So you can see the mineralization of the bone. So this is the information which an X-ray gives you. Besides this, you can find any fractures. This can also be very nicely evaluated on the X-ray. So this is the image which is taken with the CT. So the CT shows your knee joint also very nicely and very gives the entire details of both the internal and external anatomy. MRI is something like we can see the gold standard for all kind of imaging. So you can see the muscles can be seen very nicely, and the joint, and even the internal anatomy is also very nicely seen with the help of MRI. So this is the image by which you can evaluate your knee joint. You can see all these the cartilage over here. You can see the cruciate ligaments. You can see all these lateral and medial and lateral collateral ligaments also on this MRI. Now coming to this is the image of the taken off with the help of ultrasound. So if you look at over here, this on the ultrasound, you can see the soft tissue, you can see the tendons, you can see this is the bursa area. So the ultrasound shows also a very nice picture of your entire anatomy. But in the ultrasound, you cannot have a good evaluation of the bone because the sound waves does not passes through the bone. So the X-rays and CT uses the radiations, MRI uses the magnetic waves, and the ultrasound is the high frequency sound waves. It passes through the body tissues, and then you get the image on the monitor. So that's why, you know, you can see the outline of the bone on the ultrasound, but not the entire inner part of the bone. You cannot see over here. So over here, you can see this is the X-ray view of the lateral side of your knee, and this is the ultrasound image. On the X-ray, you can see the bony structures very nicely, and also you see all this is the soft tissue. And while on the ultrasound, you see the bone only seen as a white line, and you can see this all is the tendons and soft tissues. This is the comparison of the ultrasound image and the MRI. So MRI gives you a little bit more detailed information. So over here you see with the time, as the time passes and you start getting the issues of the joint, of the knee joint. So then obviously these all modalities are used for the diagnosis of the pathology. So if you look at over here, this is the cruciate ligament, which is very nicely seen on the MRI, because to look for the internal anatomy, it is a little bit hard to find it out on either X-ray or on the ultrasound. But if you look at over here, the ultrasound, you can see a very nice, beautiful pocket of water, which is very common problem in the knee joint pain. Because you see a big pocket which is called the knee joint effusion. You must have heard that word very commonly. So that this is the a big pocket of effusion. And usually it can be as with the needle needle aspiration is done to help relieve the patient problem. And look at over here, this is the X-ray, and look at over here, this is a small little fracture, which is very nicely picked up on the X-ray. This is again the comparison between the X-ray and the ultrasound image. So you see on the X-ray, it is found that there's a small calcified part over here. So when the ultrasound is performed, so you see on the ultrasound, we see a Baker's cyst, and there's the internal echoes, which are the calcified echoes inside the this cystic portion. This image shows you the comparison between the MRI and the ultrasound. So you see all these different levels of the fluid. You see this one level, this is another, and this is another. And when you perform, when the ultrasound image you will also be able to see different levels on the ultrasound. So this is the comparison between the ultrasound images and the MRI. So these all modalities are used for the evaluation of the knee joint. Now, ultrasound has a little bit more benefits of performing the exams, because you can perform the dynamic studies, and then you can perform also the, you can perform the dynamic study, and you can check that what is the problem with the patient, because sometimes the patient about a certain motion in which they get a problem. So this is possible only with the ultrasound, because you can move, you can make that movement, and you can evaluate the patient. Besides this, the ultrasound can pick up also the vascularity. So if you see on this image, this is the normal tendon, but this is the tendinosis where there's the increased vascularity. So this is something, a benefit, a plus point for the ultrasound, that it picks up the vascularity also. This is again the ultrasound images where it shows the vessels, veins, arteries, and this is a big pocket of fluid. Popliteal aneurysms are also very common. So sometimes during the incidental finding, during the evaluation of the knee with the ultrasound, they found a big aneurysm. So these are all the plus points for the ultrasound. As I mentioned, that ultrasound, you can perform the dynamic study. So they, this is the evaluation of the knee joint, where they performed a certain movement, which is called the valgus stress. And if you look at over here, this is the normal, when the normal evaluation was done, it's, they measured this distance, but when the certain movement, which is called the valgus stress, so that movement was performed, and they found that there is a medial collateral ligament insufficiency. So that's how the ultrasound is also very helpful. Plus in multiple procedures nowadays, the stem cells and all these injections are also done under the guidance of the ultrasound, because it targets the area right at the area of problem, and then the injection is given with the help of the ultrasound. And as ultrasound is non-ionizing, there is no radiations involved in it. So this was a little bit information about the imaging in case of the knee. So now I'm going to pass the mic to the...
So I'm Brooke Luciano, and I'm going to present about photobiomodulation. So UltraRed is the photobiomodulation therapy, and LightMD is the FDA-approved medical device that we used. This is some pictures that I have of knee treatments in action. So you can do with the pads wrapping around the knee. You can do one knee or both knees at the same time. The goal of LightMD photobiomodulation is to provide pulsed LED modulating frequencies at an appropriate stage of the condition to treat injuries or disease. So where there is a life cycle to each injury, there is an appropriate protocol that we are able to follow. So in stage 1, you have the tissue breakdown, edema, possible spasms and pain, and the inflammatory process, including the neutrophils invading, followed by activated macrophages. So part of those protocols that we would do are to reduce the inflammation specifically. We have programs that target specific tissue types, but the very first thing you want to do is to basically accelerate the inflammatory process. So programs include mitigating damage, reducing inflammation, increasing circulation, and overall reducing pain. The next stage, you start getting scar tissue buildup, possible nerve entrapment, Muscle-derived nitric oxide can inhibit inflammatory cell invasion of the healthy muscle. You have muscle-derived cytokines signal inflammation invasion as well, and fibroblasts and myofibroblasts chemotaxis. So in this part, we aim to reduce and realign the fibroblasts. This is all via the LED lights that are specific to those tissue types. It's going by applying the light, you're going to release the nitric oxide locally in the cells. You're going to minimize the cytokine production, which overall is going to reduce the inflammatory cell invasions. And your fibroblasts are also able to transform into myofibroblasts with PBM. There are numerous, like I was just mentioning, the pulsed frequencies. So along the top level, you'll see different biological responses and the reflexes of the tissue. So on the bottom are specific protocols that we use. So you can see in the wounds protocol, it addresses soft tissue, which is dermal and in muscle. Circulation programs are good for the circulatory and vascular system, as well as the lymph system. The bone joint protocols are good for dense tissue and also calcifications. It's good for ligaments, tendons, and bones. Combo protocol, we use this one a lot for specifically stiffness. It's good for soft and dense combination tissues. We found really fast effects when doing this when somebody does have stiffness or scar tissue to use this program before A.R.T and soft tissue manipulation like Dr. Conley was mentioning. The third, or in the E column, we have pain management. Now, pain management is one of our highest frequencies, which is able to reduce nerve pain. So this one's good for nerve, all systems and tissues, large muscle groups, and even scar tissue. Chronic is good for the bones and scar tissue and also inflammation. And then the last program would be inflammation, and that's good for straight inflamed tissue, systemically or acute. Here's another picture of a different way that we can wrap the knees. Instead of around, we're going lengthwise, and that can really also access the major muscle groups too. And so you've got your quad and down into the tibia and fibula and into your calf. Photobiomodulation for maximizing the efficacy of the therapy. It's all about delivering the right wavelength at the right energy to the with the right power and the right pulse. And so by that meaning that we can, with this device specifically, it doesn't use just one particular wavelength, one or two wavelengths. We use hundreds of wavelengths. And so you're getting on both sides, both like, for example, for red, instead of just 660, you're using almost the whole entire 600 to 700 wavelength, not exactly, but close there, and also in the infrared spectrum. By using multiple wavelengths in a broad spectrum, you can invoke the full PBM effect without overheating. As I mentioned, delivering the right energy dose, which is measured in fluence. So photobiomodulation therapy is biphasic, which means that it can go both ways. Like if you don't have the right amount of power, or you have too little power and you don't have the right wavelength, it is going to reduce the efficacy. So as there are more and more studies being published, they're finding to maximize the benefit of light therapy is to really regulate the amount of fluence. And so that is usually measured in joules per centimeter squared. In the, and delivering the right power. So you want to prevent epithelial reflection and refraction. And this is via the light pads. We have light pads that are able to conform to the body to basically maximize the amount of energy and light that is entering the body. So by controlling all of this, you're able to control the brightness, uniformity, and the time. It's all preset into our system. So without holding a laser or a handheld light device, you're able to treat, as I showed in the pictures before, you're able to rest the pads on the body. The right pulse modulation is in regards to the modulating frequencies that was on the slide before, in which we can treat different tissue types. This is a case study performed by Dr. Leahy up in San Jose. And this was a degenerative arthritis patient. He's post-surgical for lateral meniscus. He had a loss of 80% of flexion. He had creaky joints, feeling like the sensation of grating, and high level of pain between 6 and 9, and constant ache. Walking was hard, couldn't walk, very difficult to walk up to 20 meters. So after performing 5 sessions, and they did a series, so the inflammation twice, skin 3, bone joint. So those are all different types of frequencies. And after 5 treatments, he is able to walk without pain for over an hour. The crepitus is now very mild and only under weight bearing, and his flexion was able to increase to 120 degrees. Here's another case study on a knee contusion performed by Dr. Khan, who's a general practitioner. If the symptoms started after direct force trauma injury, and he did 3 40-minute sessions in a period of 9 days, I believe, or something near there, and was relieved of his pain. This is a former basketball Stanford Cardinal and former basketball player. I actually facilitated this treatment with Dr. Leahy, and I had treated this gentleman 2 years prior to this picture of him doing a session. And the last time I treated him, and 2 years before that, was the first time he had dunked in 5 years because of previous knee injuries and stiffness. So when I did Mr. Mosley, I did an UltraRed Light session on him, and then Dr. Leahy performed an A.R.T. session, and he said, and Mr. Mosley said, the real test of this is going to see if I can dunk. So immediately after he left the doctor's office, he went to a gym. He sent me a picture, actually a video of him dunking. So that was, I mean, just immediate results, and he was very happy. So I thought that was funny. Our next case study is from Dr. Khan, and it's a knee strain with heel bursitis. It's a jogger. And so he performed 6 sessions in 1 month period of time, and no pain after that, and no recurrence of injury since then. This is my other half, Jeff McKeever. And when we met, this is actually in the beginning, before we were a couple, and he was a former NCAA D1 soccer goalkeeper. He had a medial meniscus tear, grade 3, pain level 6 to 7. He was recommended surgery. He had a previous meniscus surgery on that knee when he was 12 years old. Arthroscopic partial meniscectomy, excuse me, where they removed 30% of his meniscus. After 6 sessions in 3 weeks, and then maintenance sessions of 1 session per month for 3 months, he had no surgery, no pain, full range of motion, strength, flexibility, and joined me on this business because he became very passionate about it as well after seeing the effects himself. So for the mechanisms for meniscus strain or tear, the way that photobiomodulation works is in 2 ways. Number 1, it accelerates perfusion of fluid and nutrients into the meniscus. And number 2, it helps to heal the cells in the meniscus that are repairing and making the cartilage. This is a wound healing case study for injury to the knee. So you just see from day 0 to 3 and then to 16 how fast that it healed with the extra light. So degeneration in osteoarthritis. Osteoarthritis is the most commonly found form of arthritis in humans as a degenerative disease that affects joints as a whole. Here we're going to be talking about specifically osteoarthritis in the knee. So it can affect the articular cartilage, subchondral bone, ligaments, joint capsule, synovial membrane, and the periarticular muscles. I looked at 3 different studies here, and well, I looked at a lot more, but these 3 I specifically chose. One of them was a peer-reviewed journal that had light treatments for 3 days a week for 8 weeks, totaling 24 sessions. They found that photobiomodulation therapy modulated the inflammatory process, meaning that it did speed it up by doing the light on the knee. It actually increased the inflammatory markers before rapidly decreasing them in comparison to the placebo. It also have the decrease of inflammatory marker levels, and it reduced the morphological changes in the enzymes that are involved in the joint deterioration, including the MPO, MMP1, MMP3, and MMP13. Actually, the MMP13 reduced significantly. In the next study was a randomized controlled trial. There was 35 women with knee osteoarthritis. They used a combination of ultrasound, photobiomodulation, and exercise, and they isolated them all. They found that the photobiomodulation and ultrasound reduced pain and increased physical functionality after 3 months. And the last study that I looked at was a systematic review and meta-analysis of 22 previously randomized controlled placebo trials. And they found that photobiomodulation reduced the pain and disability in persons with knee osteoarthritis. Disability was statistically significantly reduced. There were no adverse effects reported. So overall, for osteoarthritis in the knee, we found that PBT is effective in stopping disease production, reducing pain, and improving inflammatory conditions observed in OA. This is a former professional soccer player in the U.S. national team, also MLS and Bundesliga, a European league. So he was doing treatments on his knee as well as his spine with excellent results. The machine that I use is LightMD. It's a premier supplier of the medical grade photobiomodulation. So we have over 1 million hours of clinical treatments since 2001, using all medical grade materials. It's FDA approved with therapeutic protocols and safe and effective. So this just goes over all those details. And that's it from me. So thank you. And I will pass the torch to Dr. Goswami for the finale on PRP and stem cells in the knee. Thanks.
So as I mentioned, we're here to obviously discuss about non-threatening or when there's an unstable knee injury, obviously surgery is what is needed. So a complete ACL tear, or a fractured knee is going to require some form of surgical fixation. But let's look at what the existing treatments are for knee. And I'm sure most of you guys are familiar with these. There's obviously the usual pain medication, cortisone or steroid injections, and then in different names for hyaluronic acid injection. Physical therapy, which is actually on this list the only thing with proven evidence to help. So good physical therapy, and I think very well elucidated by Travis in his talk. And then it's arthroscopy and knee replacement. Next. So let's look at the evidence, and this is derived from the literature in terms of what is the evidence of, because a lot of these treatments have been around now for at least 20 years, and they're covered by your insurance. So certainly there is enough data out there, published data, that tells us about their benefits. So with cortisone injections, several authors have looked at it, and they found that the average pain relief was between 1 week to 1 month. There are certainly some side effects on the joint. Cortisone is a very powerful chemical, and it has been shown to gradually cause more destruction of the cartilage and the ligaments, the very structures that you're trying to preserve. And even when a cortisone injection is given inside the joint, it does get absorbed systemically. And so your body can experience side effects just like taking steroids orally would. Gel injections or hyaluronic acid injections, usually they were coming from chicken rooster heads. Now there is also recombinant form, which is manufactured hyaluronic acid. It's viscosupplementation. It's a very viscous material, and it goes into the joint and it provides some lubrication. Its average pain relief is again from 1 week to 3 months, slightly better than steroids. However, it does nothing to address the degeneration of the joint, because the goal there is just to lubricate the joint. So, if your chain, I do some mountain biking, is rusty, you can put some lube and maybe you'll be fine for a few weeks. But if the integrity of the chain is starting to go away, then just putting lube on it is not going to help in the long run. But these are definitely paid by the insurance. Arthroscopy is the commonest orthopedic surgery, arthroscopy of the knee in the United States. And generally, it is actually described as cleaning the joint. My background is surgery and radiology, and that's what I would tell patients every time I would put a scope in their joint, is that I'm cleaning the joint. And I literally was actually cleaning the joint, removing what was precious and needed to stay back, because that's been the traditional teaching. There is significant data now showing that arthroscopic knee surgery speeds up the progression of osteoarthritis by at least 8 years. So we clearly weren't addressing the health of the joint by any of these treatments. So while you were undergoing cortisone injections, gel injections, multiple times, obviously, because insurance covers it. Next slide. Your joint was slowly progressing from a joint that was once normal and healthy to a joint that has now lost significant tissue, joint space, significant pain, bone spur formation, and clearly then that makes you a candidate for knee replacement, which is again fine and dandy, because a lot of patients get knee replacement, and I think in good hands the results can be good. It's still a major surgery, but it is preceded by years of decline. It's not something you go and just sign up for. A lot of patients would like to wait until they really needed to undergo a knee replacement surgery. So the preceding years prior to making that decision usually means that you've been cutting down on your activities. You can no longer play the kind of tennis you wanted to play. You can no longer kind of do the hiking you wanted to do. And then you prepare yourself for knee replacement. And then obviously, like any other surgery, it's not lifelong. Sometimes revisions are needed, sometimes sooner, sometimes later. So those are some of the things to keep in mind. Now, even as this thing has been going on for many years and a lot of patients have had the treatments, there are some emerging treatments which are scientifically proven. So everything that I'm presenting here does have a scientific paper. I haven't quoted every author just so that the slides don't get too crowded, but feel free to shoot me an email and I'll be happy to send you a paper regarding cortisone use, arthroscopic surgery, gel use, knee replacement, what the data is, PRP. So PRP, platelet-rich plasma. Next slide. So platelets are obviously a kind of cells in our blood, and they contain 10 anti-inflammatory agents. Because they come from your own body, obviously there is no side effects. Numerous studies have shown that if PRP is prepared well and injected correctly, then you can expect some pain relief, average ranging from 6 months to a year. Obviously, a lot of these studies give you an average. There's a whole group of patients that are involved in it. Alpha-2 macroglobulin is a protein found in our blood, and that neutralizes the protease enzyme that can eat up cartilage as we age. In a degenerative knee joint, the protease enzyme goes up and it can start eating up the cartilage. Alpha-2 macroglobulin is a protein, again, derived from our own blood that can be used. Its average pain relief is comparable to PRP, maybe a little bit less. Again, a lot depends upon how it is prepared. And I think that is where the emerging treatments are right now, where there's a lot of science behind them, but how the preparation is done was starting from PRP. All PRP is not same. All A2M is not same. And then mesenchymal stem cells, also just the word stem cells doesn't mean anything. It's what cells are being used, how many cells, how many live cells are being injected. But now we have published data showing that you can expect a pain relief of at least 1 to 3 years. Again, that is average. A lot depends upon, again, the number of cells used, the protocol used, and a lot of other factors. So these are some emerging treatments that one should keep in mind. Obviously, next. They do come with the disadvantages of cost, lack of standardization, as I mentioned, because there's no apples to apples comparison, which can get very confusing for the consumer. There's a lot of false advertising too. In our own clinic over the past 10 years, it's taken us a lot of research insight into our patients to really figure out which are the patients we can truly help with these treatments. The advantages obviously are quality of life. If you want to maintain your joint functional, want to continue to do the activities, some of these emerging treatments can be helpful, provided they're applied at the right time and you're not too far advanced with your condition. Joint preservation obviously is the goal, with the ultimate goal of increasing your active years of life. Next. So those were some of the highlights. I wanted to leave some time for questions. And anyway, my take-home message for anybody who's athletic is that make sure you have a good PT and a good light therapy device to help you on a day-to-day basis, because that is where you prolong your active life. And then obviously, when you need to see a doctor, then you at least now are a little bit more aware of all the options you have. Thank you.
Thank you, Doctor.
Thank you. Yeah, I have a question. This is Nancy.
Hi, Nancy.
Can you hear me? Hi. Dr. Goswami, I wanted to know, once you have bone on bone, I have one knee that's perfect and the other knee is bone on bone arthritis. I've had just one round so far only last year. I had one round of Synvisc injections, Synvisc 1. And I'm wondering if either PRP or stem cell injections are ever given to people who have bone on bone in the knee.
Good. That's a good question.
And does it help for a while?
Right. So it's unfortunate because bone on bone is a term that came up in the 1950s when X-ray was the only modality of looking at a knee joint. And anytime they didn't see much space, they called it bone on bone. Now, the unfortunate part is that a lot of time I've had patients who've come to me who've been told they're bone on bone, and I can't figure out, looking at their X-rays, why they were told that. So first of all, we'll have to make sure that you truly are bone on bone or not. Secondly, X-ray, as you know, is a very poor way of looking at cartilage or lining or the meniscus or the tissue. So a lot of time it comes down to how functional you are. If you are somebody who needed only one Synvisc injection a year ago, maybe that knee joint is still salvageable. I mean, I don't know, like I said. So a good clinical exam, good ultrasound, reviewing your X-rays might give us a better idea that, whether any of these treatments can help prolong, your active life. So.
Oh, great. Thank you so much.
Mm-hmm.
Dr. Goswami, there's a question from Chuck in the chat, and it says, how can all of us help you and us to have our insurance carriers move faster and more effectively to approve PRP and stem cell use?
Very simple. Next time you're referred for a cortisone injection or knee arthroscopy surgery, refuse it. Refuse it, because I'll send you published papers. Refuse it. The consumer doesn't want to question it because your card is paying for it.
Oh, I have another.
Please say no.
I have another question, a crazy question. In light of, can you hear me?
Yes.
In light of COVID, how does COVID have any impact on the use of plasma or stem cell?
Well, I mean, it's just like any other infection, and that is why you know, one has to be careful with some of the foreign stem cell products which are available in the market. You will hear, you know, some baby umbilical cord cells and other things are being sold. While they do simplify the process because you just go in and get an injection, an infection like COVID-19 or even otherwise always raises a possibility of contamination. Generally speaking, obviously, if you have active infection, you're not going to undergo a procedure. But other than when you're getting your own cells, your body is not going to receive anything that is a contaminant to itself. It's only getting what it already has.
Okay, so both stem cell and PRP are from your own cells.
Yes, yes.
Okay.
You can harvest. Your body is full of stem
I see.
cells. Those can be collected easily.
Thank you.
So I know that Chuck had some other questions too. One is, let's see, I think for Dr. Conley. So he's saying, in these quarantine times, I'm sitting more at my computer for longer periods. Is there any relationship that knee issues can be a source of occasional paresthesia in the feet?
That's a tough one. Yeah, it'd be a question of, did you ever have them before? Did they just come up during the sitting part? And the knee, the question would come to, is the top of the foot or bottom of the foot? How much time do you spend sitting? How much time do you spend stretching, kind of moving around? Paresthesias is kind of you have a peripheral one, which can come out from, you know, your hamstring or your glutes and kind of go into the foot or radiate into there. And then you have one that comes from the spine. But it's a little tricky to say, yes, this equals that.
Okay, thank you for that. And the next question he had was, where do you purchase those pillows you demonstrated in your PowerPoint slides? I believe he's talking about the foam rollers.
Foam rollers, wherever we get everything else, Amazon. Yeah, Amazon, you get them for about $20. They're, I think they're like 18 inches and they're about 5-inch diameter or 6-inch diameter, and they're great.
Awesome. And then lastly, there was a question about Uncle Ben's hemp for the knees. Do you know anything about this? I'm assuming it's a CBD type. But
yeah, it's a hemp and CBD oils. I have patients that had great success with it and had patients that had no success with it. So I tell people the same thing with icing and things of that nature is it's a very palliative kind of thing you're trying to do. You try it. If you feel like it helps, then use it. If you don't feel like it helps, then you're probably wasting your time and money with it.
Oh, I have
really hard to say yes it does or no it doesn't.
I have one more question for Dr. Goswami. What is the procedure if someone comes to your clinic with you know, I also have I've been, you know, limping with that knee. That one knee is just giving me a lot of problems. The other knee is fine. And that one knee that, you know, they told me I need a knee replacement. There's no hope. Forget it. You know, like all stuff like that. What is the procedure when one comes to your clinic? How is it decided what would be best treatment for you?
Well, good. Excellent. So obviously everything starts with an assessment. Like I said, you already mentioned a little bit, you've been told bone unbone. And so we'll take a look at any imaging you've had. I like to do, like Dr. Badal said, ultrasound is a very good modality to look at the joint, the ligaments. When it comes to the knee, it's the whole knee that has to be really looked at, you know. Muscles, if your muscles are weak, they're probably not going to be supporting your knee as much. So you're going to have more symptoms. So first thing is really an assessment of where you are. Then we look at where your goals are. What are your goals and what would you like to see? And then see if these treatments would even, maybe it is time for joint replacement surgery. Maybe it's not. So a lot of those things will become clear. Like I said, the last thing we want to do is spend time on treatments that are not going to be effective for you. So every patient is different. Every patient's goals are different. And it's very, very important to have that picture and then design a treatment plan for you. What does a stem cell injection, even if you decide or we recommend is good for you, what does it really mean? Is it going to be addressing your meniscus, your cartilage, your ligaments? Do you have a good PT plan in place before the treatment even starts? You know, what is going to be the role of light therapy? How much more supplementation you're going to need? So there are different concepts, and that's what happens that's where the four of us have come together to create this webinar series, is because we want to educate people. It's not about selling a treatment. It's about making sure that people who are looking for help to stay active and avoid major surgery, there is an option, but obviously everything starts with an assessment.
Thank you so much. Thank you.
Okay, if there's any more questions, then now.
Paul has his hand raised.
Oh, Paul. Hi, Paul. Paul Stevenson, you have your hand raised. Let's go to you.
I'm just curious. So I've gone through the stem cell treatment and twice or 3 times, and the doctor mentioned light therapy device and good PT. And so I can go to a physical therapist here and work on specifics, but the light therapy device, maybe someone could speak to that. Like, how do we know what to get and use and put to work?
So the light therapy we do is here in the office. So I have an office here with Dr. Goswami and Dr. Conley, and we facilitate treatments here. There are some home devices. I mean, people are doing some homemade devices, which I don't recommend. What we have figured out, it's an FDA approved medical device. So it's all medical materials. It's made GMP factory. It works and it works fast. So that is actually the only system that I use. I have tested other devices and none have come up so far to be as good. So as far as doing treatments, we'd recommend coming into the office. And generally we start with 3 days a week, and you can do about 10 sessions in a month for major benefit, and then reassess there.
Okay, so I don't live where I can walk into the office. I probably live 1,500 miles away.
Where are you
So what would I go locally, and what would I say? I mean, if I just say light therapy device, are they going to know what I'm talking about?
Well, where are you located? We may have a device near you.
Well, probably the closest would be Boise, Idaho. I live in Ketchum, Idaho.
Okay, so probably, yeah, the closest right now to you is in Utah. Generally, yeah, I would just search for photobiomodulation therapy, and if any doctors or physical therapists or chiropractors are offering that, I would tend to choose that over just a handheld device or something that you can buy on Amazon. The reason is because it's all about the power, really the fluence and the radiance of the light. So you want to make sure that it's strong enough, but also low powered. So it's really about the dose. And because it is biphasic, too little will have no PBM effect, and too much will have an over effect. So I'm happy if you want to email me, and you can see if you do find a device in your area and you want to just run it by me. I'm always happy to help with that.
Thank you.
Another question. Where are your offices located here in California? Do you have different ones or just one?
It's one office in Newport Beach of Jamboree and Birch.
Thank you.
Okay, let's see. All right, I think that concludes our of the month. And thank you all for attending and joining us and for the excellent questions. And we look forward to meeting here again, and we'll discuss another joint next month.
Sure.
Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you,
Bye-bye.
everyone.